Good morning. I'm Margaret Brandt. I'm the Assistant Deputy Director for Health System Performance at the Office of Healthcare Affordability, and I use she, her pronouns. So this is actually our 21st meeting of the OHCA Investment and Payment Work Group and our 9th meeting focused on behavioral. And it looks like folks have started to introduce themselves in the chat, but if you're just joining, if you could introduce yourself in the chat with your name and organization. And moving to our agenda, today we will start with an overview of the feedback we've heard from recent meetings about our behavioral health work. And then we'll discuss OHCA's recommendations for measuring non-claims behavioral health spending. And then next we'll look at the proposed methodology for measuring claims-based behavioral health spending. And then last, if time allows, we will continue our discussion of the behavioral health investment benchmark and the development and structure of the benchmark. And then before we adjourn, we'll preview upcoming topics for our next few meetings. And as always, here's a brief recap of our meeting format. As a reminder, we appreciate and consider all of the thoughtful comments from you all in the work group. And want to offer that work group members are, of course, welcome to provide discussion and offer feedback verbally. And non-work group members, we offer that you provide feedback in the chat or you send us written feedback after the meeting. And it would be helpful as your comments to include your organization as well. And as we always do, just a quick reminder of our work group members and the stakeholder perspectives that they represent. And so getting into the feedback we've heard in recent meetings where we presented an update. We presented an update on our behavioral health work to the board in February. So this slide summarizes some of the feedback we heard in that board meeting. So among the feedback we received were the following. So given that OHCA plans to begin collecting behavioral health spending data from commercial and Medicare Advantage payers first, board members stress the importance of keeping Medi-Cal in mind as we develop specifications that Medi-Cal will be added to the spending definition and data collection. And then there was some discussion of the proposed focused behavioral health investment benchmark and interest in the rationale for excluding inpatient spending from that proposal. And next, board members expressed interest in tracking over time the spending for inpatient behavioral health care, pharmacy costs, and payment rates for behavioral health services. There was also an interest in understanding the reasons for access gaps and low network provider participation and in capturing behavioral health spending in schools. And board members discuss ways to track behavioral health transformation more broadly that's occurring across the state. And then next, just summarizing some of the discussion we had in our February workgroup meeting. So we heard from workgroup members different thoughts about the payments in expanded framework category A, that's our population health and practice infrastructure payments category, that could be included in the behavioral health measurement definition. We also heard members express interest in exploring including payments outside of the claims system, but that are not made to providers but contribute to the maintenance and prevention of behavioral health conditions. And while discussing the measurement definition, some workgroup members cautioned against the definition becoming too broad. And we also heard more workgroup members agree than not that OHCA's behavioral health measurement definition does not need to align with the federal mental health parity definition. And then finally, members expressed interest in tracking out-of-network utilization, tracking in-network and out-of-network utilization. And then our last slide on a summary of feedback. So OHCA earlier this week presented a progress report on the behavioral health workstream to the OHCA Advisory Committee. And this slide summarizes some of the discussion we had with the advisory committee. So regarding the benchmark, advisory committee members expressed support for structuring the behavioral health investment benchmark as a per member per month amount rather than a percentage of total medical expenditures. And we'll, again, in our benchmark development discussion today, talk about that as well. And there was mixed support among members for that recommendation, for the recommendation that the benchmark focus on outpatient and community-based spending. And members appreciated the desire to incentivize increased access to upstream behavioral health, but also pointed out that there are, of course, access challenges across the care spectrum. And there was also concern about incentivizing untested approaches to behavioral health care, such as the use of artificial intelligence through how we structure the benchmark. Some comments focus on recognizing that behavioral health is part of a larger picture of an individual's health, and members expressed the importance of incentivizing behavioral health integration, whole person care, and there was some concern that if we only use the primary diagnosis in our definition of behavioral health, that we, of course, are missing some spending, which is we've talked about before in the work group in terms of how do we structure the benchmark to kind of balance that issue of overcounting or undercounting behavioral health spend. Other comments also expressed concern, as we have also discussed in the work group, that measurement of clinical spending by payers misses important parts of the behavioral health support system that is outside of traditional health settings. And then there was further feedback in understanding the diagnosis fields and encounter data, and if those are sufficiently populated to identify behavioral health spend. So I know that was a lot of summary of feedback and information that we've heard in recent meetings. So I'll just share, or I'll just pause here quickly for any reactions or questions from work group members. Yes, we need to go ahead.
I mean, I know we're going to talk about this, but I would just say that I agree, and we have talked about the concern of missing care if we're just focused on the primary diagnosis, and similarly, the just everything being about the cost and utilization really does feel a little like it misses a big part of the mark, which is the outcomes. So I just want to be sure that as we look at this, that we are also contemplating the quality of the services versus just the utilization of the services.
Thank you. Carrie, go ahead.
Hi, yeah, I had the pleasure of being at the advisory committee meeting, so I really appreciated the conversation. I just think on the I know that there were different thoughts about the outpatient community-based focus, but I think it was very clear from a consumer perspective that that is what makes, I think, the most sense, given the fact that folks are just not able to, they're not able to get basic care, and we know that communities of color are overrepresented in inpatient care, but often not able, just like other groups. It's not just an equity issue, but are not able to actually get that basic preventative care. So I think really just want to my takeaway was it was very clear to me that consumers, folks who work with consumers, who work with folks who are trying to access this system, understand that we really need, that the importance of this focus on the outpatient community-based services that are keeping, will keep more people healthy if they can actually access them and pay for them. Thanks.
Thank you, Carrie. And Beth, go ahead.
Yeah, just to add on to the points that Carrie is making, because like her, I got to go to the advisory committee and also go to the board meetings. Um, in addition to that focus on outpatient and preventive care, to be clear that if someone needs an emergency room visit or hospitalization or other care in a facility, they should have it. But to the extent that we can manage people's care better and to speak to the outcomes, keep people healthier. It's what we try to do, whether it's asthma or diabetes or heart disease, and it's what we should be trying to do with behavioral health and do it in network. Um, and again, I'm just going to say it is wrong that jails are a major provider of behavioral health. That is not the society any of us want to live in. We want to get to a better place. So that's how I see this work in this discussion as part of that larger effort. And certainly the board and a lot of the advisory committee members think about it that way too. We heard on Monday from an emergency room doctor who said literally, when somebody shows up in my emergency room, it's a system failure. And that's the way we want to get to a better place. And that's what this work is about. Thanks.
Thank you, Beth. Vicky.
Good morning. Thank you. I don't know how to fix these things, but it's pretty much what is being talked about, which is I'm concerned that we're engaging in documentation of what we do as opposed to understanding how to make quality, the driver and how to make prevention the driver. When we deal with diagnosed disorders, people come in with complaints that, if treated, would prevent us from going to the point of having a diagnosed disorder. And, it's kind of like in research, we think about, the NIMH RDoC model, where what you're doing is looking at signs and symptoms, not necessarily the disorder itself. And I don't know if there's like the room to be able to do that, to say, because again, I'm not sure I understand well enough where you can get all this data, but I just feel like at the end we're going to talk about what we've done or what we do, and not what we should be doing. And that's my biggest concern, because I think that, populations that I work with, they don't even get in the door to get a diagnosis until they get in the jail or they get into some kind of, carcerated setting where treatment is required. And that to me is what we want to change. Thank you.
Thank you, Vicky. And I think maybe that raises a good point that we could come back to in a future work group meeting, is about, as we set this benchmark for increased investment, how will we be tracking progress and how will we be tracking impact? And we can bring that discussion back to a future work group meeting. I know we've had lots of conversations over the past few months about, what are some other things we should track outside of spendings. So we can come back to that discussion in a future meeting. Okay, I'm not seeing any additional hands raised, so I will transition it over to Debbie Lindis to continue our discussion from last month on measuring non-claims behavioral health spending.
Thanks, Margareta. Sorry, let me move forward. Good morning, everyone. I'm Debbie Lindis. I'm the manager of the Healthcare Delivery System Group at the Office of Healthcare Affordability. I use she, her pronouns. And as Margareta said, the first part of today's meeting will return to the topic of capturing non-claim spending for behavioral health care. We'll go a bit deeper into those details and also take up some of the issues that were raised in last month's discussion. So we've refined our principles for non-claims measurement to be more specific to the California environment while still using the Milbank principles as a foundation. Measuring non-claim spending will involve a variety of methodologies for allocating some or all of a payment to behavioral health care using the expanded non-claims payments framework to classify non-claims payments. And those methods include classifying payments for population health, behavioral health integration, and care management as behavioral health only when the payments are made to behavioral health providers, limiting the portion that can be attributed to behavioral health from payments for practice transformation, information technology infrastructure, and analytics, including 100% of behavioral health capitation payments, and allocating to behavioral health a portion of other types of capitation payments using a formula that's similar to the one adopted for allocating capitation payments to primary care. And now I will turn it over to Mary Jo to walk us through the various types of non-claims payments.
Excellent. Thank you, Debbie. Good morning. My name is Mary Jo Condon. I'm a principal consultant with Friedman Healthcare supporting the OHCA team. I also use she, her pronouns. Here is a quick review of the expanded framework subcategories that OHCA is proposing to include in its non-claims behavioral health spend measurement. Subcategories highlighted in green are those for which OHCA recommends including all of the payments in its measurement. Those highlighted in orange are subcategories that OHCA recommends including a portion of the payments. You'll note subcategories A1, A3, A4, and A5. Those payments highlighted in blue were discussed at length during our last meeting, and we'll talk about them more further this morning. You'll note that OHCA is recommending including all of the payments in subcategory A2, behavioral health and primary care integration. These payments would be included in the behavioral health and primary care module. We have also highlighted green subcategories B1 and B2, C3 and C4 for performance incentive payments and episode-based shared savings payments that are made specifically for behavioral health services or episodes. Going to the next slide, you'll see here category D, capitation and full risk payments. OHCA recommends including all D4 behavioral health capitation payments and including a portion of D2 professional capitation payments, D5 global capitation payments, and D6, which are payments to integrated comprehensive payment and delivery systems. The portion of these capitation payments that would be allocated to behavioral health will be derived using the formula that we looked at last month, and we'll review it again shortly. Category E, all other non-claims payments, might include payments such as retroactive denials, overpayments, payments that were made as the result of an audit, or other payments that cannot be categorized elsewhere. OHCA recommends limiting the allocation of these payments to behavioral health care to a fixed amount. As we go to the next slide, here you will see that graphic that is a reminder of the scope of OHCA's measurement efforts, and that it does not encompass all possible sources of behavioral health care spending. The relevant section of the pie for our purposes is the dark blue one labeled clinical spending. These are clinical behavioral health services paid for by healthcare payers like commercial and Medicare Advantage plans and public payers such as Medi-Cal. We recognize that this is a relatively narrow view of behavioral health spending, and workgroup members have offered many excellent examples of upstream population-based services, wellness interventions, and other services that target behavioral health improvements. Unfortunately, the data that OHCA will be receiving will not be able to capture them all. As we have discussed, OHCA will explore the possibility of using supplemental data sources to capture and understand some of this spending. It is also important to note the risks of having too broad a measurement using a variety of data sources. It can become diffuse and imprecise, which could make it harder to focus on policy goals and detect improvements. As we go to the next slide here, and the slide after that, we want to return to some of the issues that were raised at the work group's last meeting. This slide shows some examples of what services OHCA believes should and should not be included in the measurement of behavioral health spending. The right-hand column offers analogous primary care services for context. For behavioral health care, 3 types of services are in the included as spend quadrant. These are provided as examples of clinical services for which a provider would pay, either based on a claim or as part of a non-claims payment arrangement. In contrast, a population health campaign focused on behavioral health screening or mindfulness programs to support general well-being are outside of the scope of what we would consider to be clinical behavioral health services. In a similar vein, population health campaigns focused on hypertension screening and programs to promote vaccine adherence were not included as primary care services in the development of that measurement definition. We look forward to your thoughts on these distinctions during our discussion. This next slide really dives into subcategory A3. There was extensive discussion about this subcategory during last month's meeting, and it focuses on social care integration payments. Here, we want to clarify the definition of those payments in the expanded framework and also offer some recommendations. So first, the expanded framework makes clear that A3 payments are made to healthcare providers and provider organizations. In this case, that would be to behavioral healthcare providers. The payments are for screening that behavioral healthcare providers do for health-related social needs and to facilitate connections to services related to those needs. This diagram shows different ways that a health plan may make social care integration payments. The icon labeled clinical represents payments to behavioral health practices for any social needs screening and referrals that they would do. OHCA recommends including this type of payment in its non-claims behavioral health measurement. The 2 icons on the right, connectors and plan staff, OHCA suggests these payments would not be included. An example of the first type of payment is one where the health plan pays a third-party vendor for information and referral to services. Similarly, internal spending for health plan staff to connect members to services would not be considered a payment for a clinical service. The subclinical area is more of a gray area. These are payments that health plans make to professionals, such as peer support specialists, for the assistance that they provide to members in connecting to and navigating behavioral health-related clinical and social services. Though these professionals are not licensed clinicians, they are often staff of a clinical practice, and they provide services that directly affect members' behavioral health. We encourage you to offer your thoughts on these recommendations in the chat and during our upcoming discussion. Now we will walk through the full set of recommendations for OHCA's approach to measuring non-claims behavioral health spending. In Category A, the payments for subcategories A1 and A3 would be considered behavioral health spending if and only if they are made to behavioral health providers and provider organizations. Spending in subcategories A4 and A5 would be limited to a maximum allowable amount. This is the same approach OHCA uses for allocating these payments to primary care. In that case, the limit is 1% of total medical expenditures. OHCA will come back to this work group at a future meeting with a specific recommendation for that maximum allowable amount for behavioral health. As mentioned earlier, all subcategory A2 payments for primary care and behavioral health integration would be included in the behavioral health and primary care module as part of behavioral health spend. Category B, performance payments, would be recognized as behavioral health care payments when they are made to behavioral health care providers. Looking at the next slide, here we focus on condition-related episode-based payments, which would be included in measurement of behavioral health spending if the episode of care in question is behavioral health related. We are not aware of any existing or planned procedure-related episode payments for behavioral health, nor are we aware of any health plan arrangements with behavioral health practices agreeing to take on risk for the total cost of care. So those would not be applicable at this time. Going to category D, behavioral health capitation payments, subcategory, which is subcategory D4, 100% of the payment would be included in behavioral health spend measurement. For more general types of capitation, such as professional and global, and payments to integrated comprehensive systems, the behavioral health portion would be allocated using the formula that we'll review on the next slide. As with primary care, facility capitation payments would not have a portion allocated to behavioral health spending. Payments in category E, other non-claims payments, would be limited to a maximum level, similar to the method recommended for the infrastructure and practice transformation payments in subcategories A4 and A5 that we looked at a couple minutes ago. Now we're going to walk through the apportioning formula. So here again is the proposed approach for apportioning professional and global capitation payments to behavioral health care. You'll note that it mirrors the approach to apportioning these capitation payments to primary care that OHCA developed in collaboration with payers, this work group, the advisory committee, and the board. For this example of a professional capitation payment, data submitters would calculate a ratio of fee-for-service equivalents for behavioral health care services to fee-for-service equivalents for all services in the capitation. And then that ratio would be multiplied by the capitation payment amount. As a reminder, these data will come from payers, not directly from the provider organizations that ultimately decide how to allocate capitation dollars. So the formula will serve as a best estimate rather than a precise measure of the capitation dollars spent on behavioral health care. Let's pause here for some discussion. We're interested in your reactions to all of the preceding information. And in particular, we would like to get your feedback on the proposed methodology to apportion capitated payments to behavioral health care, which of the subcategories in expanded framework category A should be included in measurement, and in particular here, if you could offer any thoughts you have on the social care integration payments from subcategory A3 that should be included. We'd also love to hear from representatives of payers about how difficult it might be to identify these payments. And finally, please offer any suggestions you have for what other non-claims payments should be included in behavioral health care measurement. All right, with that, I'll turn it back over to Margaretta for our discussion.
Thank you, Mary Jo. And it looks like folks are ready to chime in. So Nicole, go ahead.
Good morning, everybody. I think I just have more or less a quick question. Have we defined what constitutes social care? Because that's a pretty broad social care integration, right? I'm thinking we haven't, and I'm wondering if that would also help to make sure that we're on the same definition page for that. And if we did, and I've just forgotten, I apologize. I'm making you repeat yourself.
Sure. So we have, through the definitions of the expanded framework categories, so we have definitions for each category and subcategory. And I can put a link in the chat to our webpage with all of the details, but I'll just read it out quickly.
Thanks.
That we define social care integration as prospective non-claims payments paid to healthcare providers or organizations to support screening for health-related social needs, connections to social services, and other interventions to address patient social needs, such as housing or food insecurity, that are not typically reimbursed through claims. So that is our definition.
And would that also then include legal, employment support, any of those?
Mary Jo, do you want to
It's kind
jump in?
of et al, and I'm just wondering what the et al part is. Thanks.
Yeah, no, that's such a great question. Here's sort of how I think about this, and of course, would welcome the OHCA team to weigh in. But if the clinician is connecting someone to a legal service, then yes. But I wouldn't think that we would include, for example, the dollars associated paid to the attorney, right, to support that individual.
Right. It's the navigation.
The navigation,
so it's not
yes.
The providing whatever that social care is. It's the navigation to the social care that we're talking about. Okay.
Exactly.
That's an important distinction, I think. Okay. Thank you. That helps a lot. Appreciate it.
Hi, it's Beth. I'm sorry, I can't seem to lower and raise my hand for reasons that I can't explain, so I'm going to pop in. Back on slide 11, I have a similar, I'm just confused question. So some of these things that you're saying you're going to count are in the primary care and behavioral health module rather than in the behavioral health spending. I'm thinking particularly of A2 because I got some questions about that that I want to raise, but there are only so many colors you can use, so it's not. I'm just having a hard time understanding where we're counting that because you said verbally it was counted in the combination primary care and behavioral health module.
That's right, Beth. So it would be counted as both primary care and behavioral health spend. And when we're measuring, let's say you come to OHCA in 2 years and say, well, how much did the state of California spend on behavioral health and primary care together? We'll use that module to subtract it once so we don't double count.
Okay, but if, for example, there is a primary care visit during which there's the use of the very brief version of the screening for adult depression screening tool, which I can't remember how brief it is, but it's, as I recall, a few questions rather than the long one. And that's like a quick couple minutes in a otherwise fairly lengthy primary care visit. Then how do we sort out the primary care from the behavior? It's that brief screening that I'm thinking about that I think we're trying to encourage but not overcount, if that makes sense.
Yes. So it's a separate, if it was billed on a fee for service basis,
no,
it would
I'm
be
talking about, yeah, that's easy. But it's when we're in the non-claims environment.
So in a non-claims environment, that screening happened. And could you say more about the type of non-claims payment that you would envision paying for that screening in a non-claims environment?
Well, I thought it was A2, but you tell me if I'm wrong.
So it could be, and if so, then it would be captured. So let's say that there was a health plan that said we really want to incentivize that screening, and so we're going to pay you I don't know, Nicole, you can tell me if this is a good amount, but like $1 or 50 cents PM, provided that you and require you or expect that you will do that screening on all of your patients, then that could be considered a primary care and behavioral health integration payment, and it would become category A2 and be included.
Okay. Thank you.
Carrie, go ahead.
Thanks. Yeah, I think I have some thoughts and maybe some questions for clarification. I think on slide 14, um, I think the way you have it does make sense, right? Like, ideally, the primary care provider is doing that behavioral health screen. Like, that's what we want, is to see more of that primary care doctor, sort of thinking about the holistic health of the patient. I just wonder, to what I guess the question I have is, in a are there situations where, and we heard about this, I think, at the advisory committee meeting, where the primary care doctor has a 15-minute visit, realizes, or 5-minute visit, realizes it's a mental health issue. This was one of the clinic providers who said then they step out and they bring in the behavioral health, um, you know, uh, like practitioner to continue the visit. So just I guess I don't know the answer to this, but I just thought that was an interesting example, and maybe it makes sense for it to be to stay under that primary care doctor who made the determination that this needs to go in this other direction. But I'm just curious, like, to what extent, who's providing the screening is important or not important here. And so that's just a question I have. In terms of, mindfulness programs, I can imagine, like a meditation program, maybe that doesn't count on the one hand. On the other hand, CPAN has done a lot of work on community defined evidence practices, which are, culturally and linguistically, attuned to communities, and some communities don't, maybe there's stigma, or they don't believe in traditional sort of clinical mental health, but they do a sweat lodge, or, other type of, like a other, or a church group or something that helps to deal with mental health issues. So these are questions. I don't have easy answers, but I think I'm just, want to think about this a little bit, because I want to make sure that we're not, missing potentially, swaths of what we'd love to see more of, in terms of behavioral health, that may not be included. And then lastly, just on slide 15, strong support, for including subclinical care. I think, we'd love to see the work of peers, the work of, CHWPRs who specialize in mental health or behavioral health, being included and counted. And to me, just these are just like my first impressions. Again, I want to think some more, but it seems like, the connector and plan staff, those are duties that plans are getting paid to do, to coordinate care. And so, I think I agree with the approach that this is, we want to see more of the actual referral and the service being provided. Thanks.
Thank you,
Hi,
Carrie, for that feedback. Oh, yeah, go ahead, Monica.
Hi, this is Parnika Saxena. I'm a geriatric psychiatrist and representing the California State Association of Psychiatrists. And I'm sorry, I wasn't able to attend the last meeting because of clinical responsibilities, but I just wanted, just a little bit concerned about slide 14 about what's included and not included. One thing that really struck me probably is just, even though I'm a psychiatrist, I'm a geriatric psychiatrist, so I end up being the de facto primary care physician for a lot of folks and end up straddling those two fields sometimes. But I feel like the things that are included in primary care, which include vaccine administration, smoking cessation counseling, I would see them as preventative to, prevent further illnesses from developing like hypertension, strokes, hyperlipidemia. Vaccine administration would reduce the risk of certain communicable diseases occurring. But I feel like when I look at what's included in behavioral health and what's not included, we're not including preventative care for behavioral health issues. It's great that we are including collaborative care, integrated care, which is an absolute need. But I am concerned about things like mindfulness programs, or even like population health campaigns, which are focused on behavioral health screening, not being included. Um, I, especially as somebody who works with older adults, a lot of what we focus on is prevention, but also using non-pharmacological therapies to help people. And I mean, not only are we doing it in the older adult population, but also younger adults. And I think that if you go to any psychiatry or behavioral health conference, that is kind of the that's the focus, that has been the focus for the last couple of years, and it's going to continue to move in that direction, where people are going to look at non-medication treatments, because a lot of people with behavioral health or mental health issues often have chronic health problems. They don't have a one-time illness like a pneumonia or some kind of infection that you treat with an antibiotic and you're done. So that is one thing that really stands out to me. And I feel that it would be helpful to have that as included in the spend, because number one, a lot of people spend a lot of time doing good work in preventing worsening of mental health issues, and also ensuring that further episodes are not as severe or actually do not happen. So my thought would be that we should probably include some more of the preventative behavioral health treatments. Thank you.
Thank you, Parnika. I think before we go to Vicky, I think just want to kind of refresh us or remind us about our scope of data collection, which presents a limitation and a challenge to how much of the preventive work that we can include in how we're measuring behavioral health spend. So, as we've discussed before, and that our scope is collecting data from payers. I think as much as possible, we would be interested in including the prevention spend from payers, but really need to kind of focus on how we're collecting that data. So we're collecting data on clinical spending, claims and non-claims from health plans, from payers. So in that scope, I think we're looking for feedback on how we could best capture the kind of preventive work that's paid for by payers, and how we can best include that in our spending measurement. But we will not, we're not more broadly, as we've discussed before, one of our limitations is how we're not broadly capturing the variety of spend on behavioral health across the state. So I just wanted to kind of refresh and remind folks that one of our focus is measuring how much behavioral health spend is occurring by payers, by health plans, which can limit us in how we're looking at this, but would welcome more discussion about how we better capture prevention spend by payers. And go ahead, Vicki.
This may have been discussed before, but are you going to have data on psychiatric prescriptions? Yes, okay. Can you track the date of the prescription to a provider visit? See, part of what I'm trying to get at is the difficulty of what happens when people really can't get mental health care. Primary care really does a lot of taking care of people. And in a regular visit, they will check on, are you still feeling anxious? And, how's the prescription doing? And, so time is spent, and we're collecting data. It appears in a way in which we want the world to be, but it's not how it is. And I'm trying to figure out, if there are creative ways to do linkages that will give us a better sense of what happens in the primary care setting. Because for behavioral health, it needs to carry its own weight, but it can't because of, the unavailability and excess access kinds of problems with getting to providers. So a lot goes on in primary care. And I also agree with this notion about prevention. And since we're using claims-based data, I don't know. It just seems like we're using what we have. And the question is there a scope of work that would allow you to do a smaller study of, say, two federally qualified health centers or something that could give you some indication of what you don't have large data sets for? It just feels like it's not real what we're doing in the sense of what we need. It's the reality of what really happens is different than the way we're using the data. And I just feel like at the end of the day, we're saying to the community, well, this is what we see. And it's like, big chunk missing. So can you do a smaller study?
Thanks for that suggestion, Vicki. I honestly, I'm not sure. I'd have to take that back and think about that. And I think what we're really tasked with is, you know, it is measuring behavioral health spending as we see it in these large data systems and through the data collection process that we have. Um, but that doesn't, but we also want to, in our reporting of behavioral health spend, of course, acknowledge all of the behavioral health spend that occurs outside of our data collection. So I think we aim to be, and we will in our reporting put this behavioral health spend data in context in terms of how limited it is, like how it captures kind of this small piece of behavioral health spend, but does not broadly capture everything that's occurring across the system.
Yeah, and
I
if
would
I could
like to
just,
really
if
consider.
Vicki, if I could just add
Yeah.
just a couple framing things. We're starting off with commercial health plan in-network spending and Medicare Advantage. We will get to, I hope sooner rather than later, Medi-Cal, precisely, because of what you're talking about. So it's, it, on behavioral health, it's even more frustrating than it is on other things because of exactly the issues you're raising.
So the only thing I would say is consider whether you could do a small pilot of some kind to indicate the next step of what's necessary. That's part of what you're pointing in the direction of. And again, I don't know if there's money for that, but it just seems like it's a balance act. This is what we see in here, but if you were to do this might be what you learn even more about. So.
Thank
Thank
you.
you.
Yeah. Yeah, Kirsten.
Good morning. Kirsten from the California Hospital Association. Unfortunately, today I have to hop off for a 10 o'clock, so I wonder if you would mind me asking a quick question that's on an item that's just about 2 or 3 slides ahead. And let me know if not, I can take it offline. But the basic question is um, about the inclusion of mobile behavioral health services. Question for you all and maybe even others in the group. is that something that's actually available and paid for by anyone other than Medi-Cal at this point? I'm not aware that commercial or Medicare have mobile behavioral health services in the community.
Good question. I would love for any commercial payers to jump in if they have a. Oh, and thank you, Sarah. So Sarah Arnquist just noted in the chat that law requires commercial plans, commercial Knox-Keene plans to add it to their explanation of benefits.
I'm pretty sure it was SB 855, but I'm trying to verify that, but I'm pretty sure that's which one it was.
Okay.
Gotcha.
So if you
So this
check
is kind of like
if you check Knox-Keene EOBs now, you will see mobile crisis listed, and Brad Lerner, who represents Carolina, and he's confirming.
Okay.
I guess my question isn't so much whether they'd pay for, typically that's a county operated benefit that sometimes now health plans, right, are being required to cover if it's provided. But I guess my question is, um, are health plans or Medicare actually setting up contracts with anyone other than like a county Medi-Cal mobile crisis team, for example? Does that make sense? Like on
Like
their
building
own.
their own networks for it is what
Yeah.
you're asking. Yeah. I can't answer that question, but I hear the distinction that you're making in the question.
Yeah, Kristen, we could come back to
But
that
maybe
and
that's
then
why we measure it, right? Because like you start with measuring it, and if it's 0, well then we know there's a baseline.
yeah, thanks, Sarah. And I think also our intention is as much as possible. I know we haven't like really delved into Medi-Cal behavioral health spending yet, but our intention is to develop this definition to try to capture so that we Medi-Cal spending so that we don't have to change it too drastically when we revisit how we would define behavioral health spending for Medi-Cal. So even though, mobile services may be very low spending in the commercial market, I think we still want to capture that spending and understand it and, have our definition be applicable to Medi-Cal where it can be. Okay.
Gotcha. I just think that one just kind of note is that a lot of what's being set up in the community for quote mobile, I would say street medicine aside, but mobile tends to be crisis oriented, which is sort of the opposite end of the spectrum of what this group and the board have wanted to kind of promote access around. So while we've said, we want to count ED visits, we want to count when people have inpatient stays, we want to count when they have crisis services, those are not so much benchmark. So just point out that by including mobile, you're kind of including a crisis oriented service most likely. Because I don't think those tend to be like, it's a home visit just to check on how you're doing. Those tend to be much more crisis oriented, not upstream.
Would the place of sorry,
Go ahead, Sarah.
sorry, I did not raise my hand. Hector had his hand up. I'm jumping the queue.
No worries, Sarah. You can go ahead.
My question was, um, to Kristen's point, a crisis service, you could distinguish with place of service code. It's still crisis, but crisis service in the ED versus like crisis service in the community. There's a preference for at least a crisis service responding in the community and preventing the emergency room visit, right? And so you could, by excluding any crisis services that have a place of service in an emergency room, you would at least only capture those that happened in the community.
Thanks, Sarah. And Hector, go ahead.
Yep, I was going to raise a similar point that I think there's a distinction that we want to make between mobile crisis services and other type of emergency or crisis services in behavioral health
Mm-hmm.
because of the components and characteristics that we really want to elevate, right? One of those also being connecting people to other services. I know this can happen at an emergency room too, but again, mobile crisis services are sort of defined in a way that prevents these other levels of care that we may want to prevent. So it's the the more effective alternative and community-based alternative.
Thank you, Hector. So I think before we move on to our claims-based behavioral health spending definition discussion, just wanted to do another call for any additional feedback on the proposed methodology for non-claims. And it sounds like from, at least I saw from the discussion in the chat, we should maybe come back to some potential spending that may be in the other category related to mindfulness or other potentially other spend by payers that might be categorized in our other non-claims category. Okay, I'm not seeing any other feedback, so we'll come back to some of these conversations and look to make more recommendations as we move forward. So I will turn it back to Mary Jo to kick us off for our claims-based behavioral health spending definition.
Thank you, Margaretta. Our next agenda item is looking at OHCA's proposed methodology for measuring claims-based behavioral health spending. And this methodology includes the claims codes that would be used to define behavioral health spending and how those codes would be applied. So these are the high-level principles on which OHCA's proposed method for measuring claims-based behavioral health spending is based. So first, all claims with behavioral health diagnosis, a primary behavioral health diagnosis, will be included in the measurement of behavioral health spend. In addition, claims for mental health or substance use disorder screening or assessment will be included in the measurement regardless of whether the claim includes a primary behavioral health diagnosis. These behavioral health claims will be categorized based on place of service code, revenue code, and service codes. The categories are relevant both for reporting purposes and for identifying spending that would be included in a focused behavioral health investment benchmark, which we will discuss shortly. I will also note here that OHCA is considering applying a service code filter to the other behavioral health services category to guard against including claims where there was a primary behavioral health diagnosis, but the service is clearly not a behavioral health service. Finally, a set of national drug codes will determine whether a pharmacy claim should be included as either mental health or substance use disorder spending, independent of diagnosis. On this slide, we see a proposed process map that brings together the steps for identifying behavioral health claims. So starting with the top left, you'll see the blue box there. The first step is to determine whether a claim includes a behavioral health diagnosis in the primary diagnosis field. If the primary diagnosis field does not contain a behavioral health diagnosis code, the claim may still be considered behavioral health if it includes a service code for mental health or substance use disorder screening or assessment. The orange box underneath recognizes that screening for mental health and substance use disorders is important for prevention and population health, regardless of the resulting diagnosis. OHCA's measurement approach should incentivize these important services. So, if one or more of those services is on the claim, then those lines of the claim are considered behavioral health. Now we'll go back to the first blue box. If the claim includes a behavioral health diagnosis code in the primary diagnosis field, then the next step is to categorize the service by place of service code, revenue code, and service code. A claim that clears the primary diagnosis hurdle will be considered a behavioral health claim. This step is really to categorize the claims for analysis and later to determine what will be included in comparing spending to the focused benchmark. You'll note that there is a separate flow starting with the blue box on the right side of the slide that shows the process for identifying a pharmacy claim to be included in measurement. If the pharmacy claim includes a national drug code or NDC code that OHCA identifies as behavioral health treatment, then the claim is included as behavioral health. If not, the claim is not a behavioral health claim. Please note that all claims will be categorized as either mental health or substance use disorder spending, depending on the primary diagnosis on the code on the claim or the NDC code on the claim. All right, this slide shows how we will recommend the behavioral health service categories from the process map that will be rolled into higher level service categories. The categories would be used for reporting and for identifying spending that would be measured against the focus benchmark. So here up top, you'll see the outpatient community-based category. This is shaded in blue. And this includes 4 subcategories that would be included as part of the focused benchmark. One methodological question is how OHCA should ask data submitters to identify claims for behavioral health screenings and assessments. There are a couple of options. The first option is that screenings and assessments could be their own subcategory of spending, and that payers would submit these payments as part of a group without regard to where the service occurred. So regardless of where the screening happened, they would all be in the same category. Assuming that screenings and assessments will be included in the focused behavioral health benchmark, this would simplify the process for OHCA. The main challenge of this approach is that it would increase slightly the burden for data submitters, who would need to separate the spending for these services from other patient care that is part of the claim. All right, if we go to the second option, and that is to include screenings and assessments as a component of each relevant subcategory, distinguishing them by care setting. In this approach, the benchmark would only include the screenings and assessments that are done in the care settings that are part of the benchmark, so outpatient and community-based, for example. This approach would be less of a burden for data submitters and has the benefit of being consistent with the categorization of services using the other care setting codes. In this scenario, OHCA would not be aware of the volume of payments for screening as assessments, as they would be folded into the subcategories. So we're going to pause for discussion in a few minutes, and we'll be interested in your feedback on these two pieces. Now I'm going to turn it over to Debbie to talk through the claims code set.
Thanks, Mary Jo. So at the technical level, The designation of a claim as behavioral health spending and the categorization of that claim are driven by a set of codes that identify diagnoses, services, care settings, and for pharmacy claims, prescription drugs. We'll review some examples of codes in each of these categories in a moment, but first, as background, service codes are the CPT and HCPCS codes that apply to behavioral health services. There are 586 service codes in our current draft code set. Care settings are defined by either a place of service code or a revenue code, and there are 238 care settings in the draft code set. Diagnosis codes are behavioral health related ICD-10 codes. There are 2,950 diagnosis codes in the draft code set. And finally, national drug codes are subdivided into mental health and substance use disorder treatments, and there are 164 drugs in the code set. So the guide that data submitters will use includes all of the specific diagnosis, service, place of service, revenue, and national drug codes they can apply to identify behavioral health claims. So as I mentioned, there are 586 service codes in our draft code set, and these are just some examples of service codes that are categorized into two of the reporting categories. In the outpatient community-based category, we include services such as psychotherapy, pharmacological and care management, preventive services, medication-assisted treatment, and community support and peer services. The emergency department category includes services such as evaluation and management services for patients with behavioral health conditions and critical care services. Similarly, the inpatient and long-term care and residential treatment reporting categories would include services relevant to those settings. So for the inpatient category, we've included services such as hospital care for evaluation and management of patients with a behavioral health condition, inpatient consultations and pharmacologic management, and detoxification services. And the long-term care and residential category includes services such as detoxification residential addiction program services and non-acute behavioral health services for patients at those facilities. So these examples are not exhaustive, and we will appreciate that as you are reviewing the entirety of the code set in the near future, you may well identify some additional services to recommend adding to our code set. So here you can see how the reporting categories and their associated service subcategories are mapped onto place of service and revenue codes. There are 238 care setting codes comprising both place of service and revenue codes that OHCA will use to categorize behavioral health spending. And I definitely want to note that we do not plan to restrict spending included in measurement to these care settings, but we will use the care settings to help categorize the spend. Categorizing facility spending in the reporting categories will be based on the use of several revenue codes, such as intensive care units for inpatient, emergency rooms and associated professional fees on facility claims for emergency department, and so on. Spending for the professional service subcategories will be categorized under using place of service codes on professional claims, such as psychiatric residential treatment centers for long-term and residential care, and school, home, office, and others for outpatient care. So there are nearly 3,000 diagnosis codes that will be used to identify claims with a primary behavioral health diagnosis for inclusion in OHCA's behavioral health spending measurement. I know we've talked about diagnoses in the past, but we wanted to share this list of diagnosis categories for your feedback. The list includes diagnoses like anxiety, emotional disorders, and personality disorders, as well as dementia, developmental disorders, and disorders due to psychoactive substance use. There are 164 distinct drugs included in OHCA's NDC list. Each of these drugs has multiple NDCs associated with it based on factors such as dosage, packaging, and brand names. Examples of the types of drugs included are those used to treat conditions such as anxiety, depression, PTSD, and substance use disorder. I want to note that pharmacy claims often do not have their diagnosis fields well populated. So we expect that sometimes these drugs may be used for purposes other than to treat behavioral health conditions. OHCA believes that capturing spending on these treatments is a critical part of behavioral health care and will include them in spending measurement despite the imperfections in measurement. And this is consistent with other states' approaches to behavioral health spending measurement. So we'll pause here for more discussion about OHCA's proposed methodology for measuring claims-based behavioral health spending. And we're particularly interested in your thoughts about how place of service, revenue, and service codes are grouped into categories and subcategories for measurement and reporting. Those two options Mary Jo presented for categorizing behavioral health screenings and assessments, and then whether there are code categories that should be either included or excluded from the code set. Sarah. Go ahead.
Where do IOP and intensive outpatient and partial hospitalization go? Would they be in the outpatient facility? Because they use revenue code. They sometimes get paid from revenue codes and their hospitals often.
Yeah, great question. And Mary Jo looks ready to chime in with an accurate answer. Thank you.
Oh, yep, if I can come off mute. Let's go back a couple of slides to that table where we have, right here. So Sarah, I think what I'm hearing you ask a question around is essentially, would those services go in the outpatient community-based row, or would they go in the inpatient row? Is that right?
I guess I was assuming they would be in the outpatient row, and then I got a little confused if my assumption was correct.
Yes, I believe that's correct. Vinayak, feel free to tell me if I'm getting that incorrect. But
Okay, I think
correct.
I would recommend listing them.
Okay.
It's like I guess this is just examples, so this isn't comprehensive, so that's okay. But they're big parts of especially in the commercial and the Medicare side.
Distinct level of care. Yeah.
So so we can include those as a specific example under the, or I should say in the row, outpatient community-based row.
Yeah.
Mm-hmm.
Arnica.
Hi. I had a question regarding slide 25, which said for separate subcategory and or reporting category, potential to increase data submitter burden. I was wondering if you could explain that a little better. The reason why I just ask is this might be an information.
Tired. I'm tired. Yeah. I woke up and I was like dizzy tired. I walked to the bathroom and I was like,
Oh, sorry. It might be an information gap, but I'm just thinking that when I'm submitting codes and claims, things like that, well, number one, I have to list. There's a code for where I'm providing the service.
Mm-hmm.
Whether it's the ED, is it a consult to the ED, is it inpatient, is it a consult to the inpatient, is it outpatient, and also, as you pointed out, a lot of the codes inherently will tell you what the setting of the care is, right? Like providing medication as a psychiatrist, a code to see a patient outpatient is going to be different than inpatient. So if you could just help me understand, how is the data submitter burden getting increased?
Debbie, do you want me to walk through that for a minute? Sure. So you're absolutely right. All of that information is provided on the claim. It really comes back to when they're walking through that sort of flow chart of the analysis. How many times do you have to go through that flow chart to pull out those claims? So, for example, if under option 1, separate subcategory, you would have to go through each of those claims to look for that specific claim line that would have that screening and assessment, because other services may have been provided on that claim as well, not just the screening and assessment. So you'd have to go through all those claims, look for that screening and assessment, and then pull it out into its own category. Whereas under option 2, when you were categorizing the entire claim as a specific category or subcategory, I should say, you would just put all the spend in that subcategory.
So it sounds like it might not be so much of a data submitter burden, more of an analysis burden from what I'm hearing.
Well, yes, although I will note that the data submitter is the one doing that work. So the information that comes in to OHCA is information with that analysis completed by the data submitter. And so that's why it's referred to as a data submitter burden.
Okay. But I'm just wondering, like, sometimes like when somebody comes to the emergency room and there's a plan to admit them to the same hospital, it often goes through the same encounter. So I don't know if that'll get bunched as one claim. And I don't know if that'll make us miss some data if we are lumping it all in one claim versus if somebody comes to the emergency room and goes outside to another hospital. And maybe I'm incorrect, but just because I do these admissions all the time, I think it might get bunched into different claims. So I don't know if we're going to miss data if we lump it all. If we don't look at the subcategory.
Yes. So just to clarify, these two options are specific to BH screening and assessments. So really just focusing on this slide on for those screening and assessments, for example, if the screening occurred in an inpatient setting, would we count that screening as inpatient spend, or would we count it as part of a separate category focused just on screening and assessment? And I think what I maybe hear you saying is that if we try to pull it out, we may miss it. And so it may be better to just include it with the overall subcategory. Is that right?
Yes, yeah. But I also want to point out, like sometimes you'll have two screenings happen. It might happen in the emergency room level, but it might also happen on the inpatient level. Because sometimes, there's review of does this patient still need inpatient level of care when they come in, and that might actually get billed as a full screening and assessment. So I would think that ensuring that we're looking at least a subcategory of place of care provided or setting would be beneficial.
Okay, thank you.
Catherine, go ahead.
Thanks. And I think this is maybe a little bit of a follow-on, but I was, and I just don't know anything about this, the line at the bottom about whether screenings and assessments are or are not billed separately. I was just really curious from from those of you who actually do this, if we have a sense of how often that's the case.
Don't know that I do.
That's all right.
I think I could take a stab at it, Catherine. I think that probably in capitation, that's not going to show up unless we have encounter data, which isn't always the case.
Yeah, thanks, Nicole. That was my hunch, but anyway, just curious.
And I think the other thing about even not in capitation, the other place I know that we've started trying to do some outreach work is reminding providers to bill for those. We know they're doing them, and oftentimes we're not catching it just if they're also just not billing for them. So another time. I think it's pretty not haphazard, but not consistent in the way we would want from a number of perspectives.
Yeah, I think that's what we've heard from providers in other meetings, that unless there's a very specific incentive to code it separately, either a financial incentive or some other kind of quality metric, that it's often done without any documentation of it having been done. But I don't think we have any numbers to quantify how often that's the case. Good question. Thank you. Other questions or comments about our claims-based categories, subcategories? Okay. Very quiet group. Margaret, I don't know if we have time. Last time we kind of got started and weren't able to finish, but shall we start again on benchmark?
Sure. Maybe we could just quickly run through the slides, and I think, like we did last time, would encourage folks to think about these key decisions for framing the benchmark, and then we'll wrap up.
Great. Okay. So we've gone over this before, but just as a quick reminder that we're proposing to distinguish our measurement of total behavioral health spending from the focused benchmark, which will apply to a subset of spending that's designed to promote specific policy goals. These are the 3 key decisions, and I will not read them all here, but we'll go through each one separately. So the first decision is about should the benchmark encourage payers to increase behavioral health spending to a certain level, measured as a percentage of total medical expenses, or TME, or frame the benchmark as a per member per month amount. OHCA's statutory mandate suggests a preference for the TME approach. Also, setting a TME-based benchmark communicates that increased spending on behavioral health should reallocate healthcare spending rather than lead to an increase in total spending. And this is consistent with OHCA's approach to primary care investment. Some reasons we might want to consider a per member per month approach are that it might better reflect the cost of achieving behavioral health delivery goals. It can guard against the benchmark becoming unnecessarily inflationary if total medical expenses increase more rapidly than expected. And it's also more consistent with how payers typically measure healthcare costs. You may recall from a prior meeting that Rhode Island bases its benchmark on a change in per member per month spending. And the second question is, should OHCA be setting an annual or biannual improvement benchmark, specifying incremental improvement for each payer over a series of short time periods, or should the benchmark focus more on a statewide goal achieved over a longer time horizon? Or should we adopt a combination of those two? An annual improvement benchmark meets each payer where they are today and recognizes differences across payers and patient populations. It also allows for short-term adjustments as actual spending levels become clearer with submission of data in the early years. And then in contrast, the long-term investment benchmark offers a vision for the future across all payers. It can realistically reflect current thinking about the right level of spending, as well as the long-term infrastructure needs to reach the benchmark and the budget needed for that infrastructure. And then a combination of the two approaches can capture the benefits of both and parallels the structure of the primary care investment benchmark. The final key decision is regarding timeline, and some considerations for this are that OHCA believes the benchmark should be aggressive in pursuit of the underlying policy goals, and at the same time, it should reflect reasonable expectations of how long it will take to achieve. We may also want to align the benchmark timeline with OHCA's other adopted benchmarks, the spending growth target set for 2029, and the primary care investment and alternative payment model adoption goals for 2034. And this slide shows those other benchmarks in a little bit more detail. As you can see here, OHCA's overall spending growth target starts this year at 3.5% and tapers down to 3.0% by 2029. And then in parallel with the future behavioral health investment benchmark, payers will be working towards the alternative payment model adoption and primary care investment goals, both of which combine incremental and long-term goals, with 2034 as the timeline for achieving those longer-term goals. And here are OHCA's recommendations for the subset of total behavioral health spending that would be included in the benchmark. So as we've discussed already, OHCA recommends that the benchmark should focus on community-based and outpatient care settings. And this would include the subcategories of claims that make up the outpatient community-based services category that we saw a few slides ago. The proposed benchmark would also include all non-claims payments allocated to behavioral health in the expanded framework category A, population health and practice infrastructure payments, and category B, performance payments. In addition, the benchmark would include the portion of capitation payments allocated to behavioral health that pay for outpatient and community-based services as identified through encounter data. And so I'm not sure that we have even 1 minute, unless Margareta wants to allow a minute for a discussion of these three key questions of the focus, the way the structure of the benchmark, incremental versus long-term, or timeline.
Yes, if anyone wants to jump in with thoughts, please go ahead, and we can kind of skip our next step slides.
Can I suggest that you give us a month to think about this and cue this up at the start of the next meeting?
Yes, we can do that. And I think it was Amy. Go ahead.
Yeah, I just had a quick question. So I kind of know what I want to say, but I agree with Beth. Give us some time to think. But my question is, as we look at APMs and those other alternative payment models, are they doing TME or PMPM?
So the primary care investment benchmark is based on a % of total medical expense. So it's a %. And then the alternative payment model adoption goals are based on the % of members covered under those alternative payment model arrangements.
Okay. All right. Thank you.
Vicki, go ahead.
To the extent that the data bears it, I think that you've really covered, some really good points here. Decision making is often in what the analysis is going to be. So I don't know the extent to which maybe the next time you can then say, well, okay, if you select this, this is how we would look at it. If you select that, this is, how we would slice it. But, just bottom line data, fine. But in terms of the analysis would be my next question.
Sure, we can next meeting we can bring back some examples of what like analysis and reporting would look like using each of these approaches, especially maybe for the PMPM and %.
Yeah.
Okay.
Thank you.
Yeah. Okay, I think. And now we're just 1 minute over, so appreciate everyone's participation and the great discussion today. So we sounds like we have a plan for our next meeting, and we look forward to the continuing discussion. So please reach out, of course, as always, if you have any thoughts or additional feedback between meetings. Happy to receive that via email, and we hope everyone has a great rest of their week. Thank you all.